This is John Gever for MedPage Today in Boston at the AASLD meeting. A problem with protease inhibitors in development is that they seem to require TID dosing. But there's one product that is just starting through the pipeline now called nirlaprovir that could be given just once daily. I spoke with Dr. John Vierling of Baylor College of Medicine in Houston, who reported a phase 2 study here of this drug.
This particular drug was selected because it's metabolized primarily through cytochrome P450 3A4. This particular metabolic pathway, we've known for a very long time in the HIV field, can be inhibited by the co-administration of ritonavir. And by doing so, it means that the amount and availability of the nirlaprovir in the bloodstream after an oral dose will be prolonged such that it can be used once daily rather than 3 times daily, which has been the case with all other proteases in development. So this particular study is the result of the cumulative effort in which we took several arms and studied the effectiveness in the first 4, 8, and 12 weeks of standard of care as a control arm, and then 2 different cohorts getting nirlaprovir. One of them was getting a dose of 200 milligrams along with ritonavir once daily, the other 400 milligrams with ritonavir once daily, along with the pegylated interferon and ribavirin, and all of those drugs were started concurrently at time 0. 2 other arms had a preceding 4-week lead-in treatment. This consisted of pegylated interferon and ribavirin alone, and at the end of that period, then there was the addition of their nirlaprovir plus ritonavir, again 200 milligrams nirlaprovir versus 400. Then there was a final arm in which there was a study without lead-in, taking nirlaprovir as 100 milligram dose twice daily, not once daily, and each of those doses concomitant administration of ritonavir. What we found in this study is you take the standard of care and you ask the question, did anyone in the standard of care group at 4 or 8 weeks achieve negativity of virus? The answer was no. Only 17% of that population did so by 12 weeks, which is referred to historically as a complete early virologic response. If you look at the nirlaprovir arms that had the 4-week lead-in, they did spectacularly well, beginning at 4 weeks, sustained at 8, and at 12 weeks you were dealing with 85 to 87% of those patients were undetectable virus.
Dr. Vierling said there were some safety signals.
If you looked at all the nirlaprovir and ritonavir arms, there was a step up in the proportion of patients with anemia. Now that's been seen in all the protease inhibitors to date, and so in part a class effect. If you look at it with respect to is the anemia that is being seen more severe with those patients receiving nirlaprovir, it tends to be more in the grade 1 to 2 range and not severe grades 3s and 4s. There was also some decrease in neutrophils, again a well-known effect of pegylated interferon. When you look at the comparisons there were not significant differences with the addition of nirlaprovir, and there are no dose discontinuations. Now with respect to anemia, people would be interested to know that in this phase 2A study, at investigators' discretion, they could use erythropoietin if they felt that an individual patient's anemia could be benefited by its use. And when you look overall, you're seeing that about 6% or so of the standard of care arm was given erythropoietin, and somewhere in the 20 to 35% of the patient populations in the other arms were given this at the investigator's discretion, and there were no discontinuations due to anemia in the study.
Nirlaprovir is now moving on to a phase 2B study. In Boston, I'm John Gever, MedPage Today.